We're doing immediate post-op. So this, we finished the surgery. Now we're going to ICU. All right. So we'll talk about the room setup. Right. So we'll talk about what a good room looks like. Basically, it's gonna be the original ICU setup room plus all kinds of other things. Right. So we're going to cry in supplies. So we have a room setup. We have a primary and secondary team. Basically, the team meaning nurse, right? What? No. You would do that too, but you're gonna cry in supplies, like in wasted supplies, like finance wastage, right? But yeah, you can cry in the supply room too before you get a report. All right. And then cardiac arrest. What if your cardiac surgery patient arrests? What do? You do not do ACLS. You have very limited time to cry. All right. So we'll talk about CSU-ALS. And so it's not fancier, it's just modified ACLS. It's a whole different thing you have to do for someone that codes as a cardiac surgery patient. This is for CABG patients, any cardiac surgery patient actually. All right, and then basically within 5 minutes, you have to open the chest. It's kind of like with a traumatic OB birth, they have to get the baby out in 5 minutes. The kind of same thing. They have to get there and do a re-sternotomy, because the original sternotomy was the surgery, right? A re-sternotomy can be from the arrest, or it can be just going back to surgery because they're bleeding or something to that effect, right? And then basically these patients don't have lung disease. Yes, there are some CABG patients that have COPD asthma, but these patients don't have pneumonia, they don't have ARDS, or they can get ARDS from the bypass machine and from the whole surgery, but usually they are fine, right? Pulmonary wise. So they should be being extubated within 6 hours post-operatively. So they arrive to the room. The most high stress piece is the first hour to 3 hours. That's at the 3 hour mark is the highest risk for bleeding. All right, usually because that's five hours in, 5 hours from the protamine reversal and such. But also it should be stabilized by that point, and then we can extubate them. All right, and we have what's called a rapid weaning protocol, which is approved and everything. I can print the policy for you. I got the good parts of the policy because then it makes people excited. All right, so I got the good parts. Anyways, you got wound care. So what is the different wound management? Because either cracking open a leg, cracking open a chest, they're putting holes in everything, right? So you got to make sure the wounds are being taken care of as well. They're doing like the radial approach, et cetera. What are some things we do for a radial graft? And then chest tubes, just a little recap on chest tubes, because chest tubes are everybody's favorite. And then mobility, so they got to mobilize, and we got to manage epicardial wires. Also people's favorites. If it wants with AV blocks, it's also pace rhythms is everybody's favorite. Is it A pace, B pace, DDD mode, VVI mode? What is it, right? So we'll talk about that. I got some good looks from the audience. All right. So yeah, so we'll talk about some all these things. All right. So you're getting a CABG. So I should probably put someone crying in a room. Right. You can cry in the supply closet too. All right. So you're getting a CABG. What do you do? All right, so first you got to make sure you have a room. Sometimes at other centers, the room's occupied. So you got to get a tele downgrade, you got to get moved out, and then you might have 30 minutes for lunch. And then 10 minutes into lunch, hey, they're calling for a report. Anyways, you got to make sure that you have a room available and the room is set up nicely. Okay, so we have a room checklist, and I have one here that we can adapt to a 8.5 by 11. So that we can have everything on there, and then we might be able to update if we need to. But we have a room checklist, report checklist, like what should I be calling, what should I be getting report on, what should I be asking? And then I's and O's, that's not developed yet, it's still in progress. And then sternal precautions. So there's things you have to make sure that we have. Everybody knows that they are sternal precautions, because if this patient goes to tele, which they should go by the end of day 1. So this is day 0 when they come to the ICU. Day 1 would be tomorrow. So by end of tomorrow, they should be going to tele by the end of day shift tomorrow, right? But what if they arrest on night shift? What do you do, right? Do you do CPR? No. All right. So you do. I mean, there are some situations we would do it, but for CSU-ALS. But either way, there needs to be some kind of signage. All right, so if Cynthia's still on the line, we got to put a sign for tele for patients that are CABG patients, so they know they're not going to run in there and start doing CPR on someone if they don't have a pulse and they're unresponsive. They should be on the monitor, right? And it depends on what their electrical rhythm is. If they have asystole, you're not going to do CPR. You're actually going to pace them. It's like, what the heck? How do you pace asystole? Either way, you're going to read the H&P. That should be available on the computer, so you can read what's going on, what was the planned surgery, because usually this well planned. We know what vessel is down or what vessel is going to be operated on. Because if you have a 3-vessel CABG versus a 1-vessel CABG, one patient's sicker than the other, right? And the STS score, mortality score. So I have a slide on STS, and we have to audit all these things. But one of the things that should be done preoperatively is know what the STS score is. And if it says you have a 9% chance of dying, that's not good compared to 1%, right? So that's good to know. And let you know if they are going to be a train wreck, because they might have an elevated creatinine, they might have underlying lung disease, they might have an EF of 20%. So there might be a lot of things that could make them unique, right? Make sure pre-op orders are all carried out, and make sure the post-op order sets are placed. So cath lab and OR team crew, they love putting the post-op order sets all the time, right? So you want to make sure those things are in place. And then what else? So the bed is ready to go. So basically your room's all set up, and the bed has the transport monitor on it, and it's ready to go to the OR. They'll put the patient on the bed and they'll come back to you, right? But they should be call and report, and they call report 1 hour prior to close, basically prior to, or 1 hour, like when they're starting to close the chest, then 1 hour, that's probably got 1 hour to wrap things up and to give you a call, right? And the circulating nurse will give you a quick report, but really your true report will be from the anesthesia or even the cardiac surgeon. Okay, so monitor can be associated before the patient arrives, right? So our G monitor can associate them to the room, to the chart, so they're available because they're in a different Cerner ecosystem, right? When they're in PACU, they're in a different system than they are on the inpatient side. So you can go and associate it. It's not going to mess up their vitals or whatnot. The height and weight needs to be accurate. Why does the height and weight need to be accurate? What's a BSA? It's what you get when you're a bachelor's in arts. So BSA is a body surface area, right? So our hemodynamics are measured per kilos, right? So Dwayne Johnson has different cardiac output than Hedda LeBlanc, right? So we have different cardiac outputs, right? It's a little bit different. All right, so we have different heights and weights, and we have different cardiac indexes. So cardiac index of 2.2 is not great, but let's say cardiac index of 2.5 is perfect for the rock. Cardiac index of 2.5 is perfect for Heather as well, but cardiac output that might be equivalent to a cardiac output of 8 for the rock or 5.5 for Heather, right? So cardiac index is more specific. Our index values use the height and weight.
I'm curious, going back to once these patients ideally go out to after day 1, is their ratio still going to be the same with one of these patients?
Yeah, they're not hard patients. They don't have lung disease. They don't have anything. They just have a gaping, not a gaping wound. Hopefully, they just have a wound in their chest that can be high risk, right? They do well. What's that? Yeah, they are not sick patients. They're going to be on the phone. They're going to be on the call bell. They're going to be not a sick patient afterward. They're going to have a chest tube, so that's going to be a thing. But that's the extent of their teliness. What's that? The CABG patients? I mean, probably at first we are not going to give them as fast, but if you're really flowing through, you're doing 5 a week. They're going to be going real fast. Or when they're going to tele, yes, everything's out except maybe the chest tube might still be there. Usually day 2, a chest tube can come out. I post out day 2, so not day 0 or day 1, but day 2 they will remove the chest tube in tele, and then the epicardial wires can go to tele, and they would then remove them. The surgeon would remove them, or their NP would do it. Okay. All right, so where we're at. So monitor associated height weight entered in, and you can put that into the monitor. You have to put in the monitor, so it has and also our Cogent cardiac output monitor needs the height and weight. And then you want to put it in the computer, all your drips, or I guess right now you wouldn't have all your drips ordered just yet, but when they do come, that's the job of the secondary nurse. The secondary nurse is doing secondary things. They're not 100% important. They are important, but they aren't going to save a life. So as the primary nurse receiving the patient, you're looking at the big picture, the bird's eye view. And you can tell them, say, hey, can you update the height and weight on 5 of my drips here? And they can do that. That's their thing. Okay. And then reports, RT should be aware, right? They should know about a patient. They're going to come back on the ventilator. And then supplies from inpatient tele rooms. So if they moved in on tele, they wouldn't get a good plan as an outpatient. They don't need to have 3 suitcases, but they should have. We need to bring their stuff over, and importantly, the IS. That's how we know that they have been an easy thing to mark over there, so we know where they're at. And it might be right on the whiteboard over there, so we can translate it. Best case scenario, you are the break nurse RRT. In the ICU that morning, you go over there, give them education, and then they go to surgery, and you're the one that receives the patient. So you kind of know them already. And then it's now time to go shopping. You're going to go and get all the things to set up your room. But first, also, you can enter this stuff before the patient comes. The IPOC, everybody's favorite, right? So IPOCs you can enter. There's an IPOC for CABG, right? It has a lot of surgical things like catheters, central lines, VTE, all the things. And just every ICU patient should have the critical care management as well. You can see critical care management has all the important things as well, VAP, MRSA, VT as well. All right, and please don't duplicate it. Make sure it looks nice and clean. All right, so these are all the things you go shopping for. You get all these things. We have a CABG cart that we made. It looks like this, but it's another cart on wheels, obviously, and it has basically everything in there. This is the sternotomy cart, and they look similar, and we'll rebrand it so it says sternotomy on it. It has a bunch of sternotomy pictures on top. But anyways, it looks like this. It's color coded. It's an old Broslow cart, and it has everything set up ready to go, hopefully. But it's again your job to make sure those things are there, that you have everything you do need. So standard room setup right there in the middle, that's posted in the supply rooms already. So you should have all those things plus what's here. Okay, so you should get some extra leads. You should have a 12 lead setup. So you have to grab the 12 lead cables for the GE monitor on the bottom right over there. Otherwise, the top left there for the wall, where you need on the wall, you need suction canisters times 3, because they're gonna come back with 2 chest tubes. Usually right now for a regular ventilated patient, using 2 suction canisters, right, for OG and for suction, right? So you need a 3rd canister for the chest tubes. And you can do a splitter on one of those for the 2 chest tubes, right? You need all the tubing for that. You need a chest tube clamps, so that might not always come. So that should be in our cart. Oral care kit is also on our standard list, but O2 flow meter, ventilator RT stuff, ABG kits, because they're going to be doing frequent ABGs. When they come back post-operatively, you need an ABG within 20 minutes. That's the goal. And then that 20-minute ABG tells you if they're really basically they're extubatable. The only thing now you need is to wake them up after that ABG is good. And then otherwise, nasal cannula, because they will get extubated in 4 to 6 hours on average. And then, of course, they need that flow meter and a 14-foot cannula so they can walk around the room, ideally. Within 2 to 4 hours on the ventilator or off the ventilator, if they don't get extubated, they need to be dangling at the side of the bed. So that's the plan for by hour 4. And then what else? So bed is going to be zeroed with 3 layers of sheets. So you're going to make you're going to cry in linen, not the linen room, but you're going to cry in linen also. You're going to lay down 3 layers. These guys are not immobile, right? These guys should be dangling on the side of the bed in 4 hours. They should be in the chair for dinner if they had a morning surgery, right? So you have 3 layers there just for the worst case scenarios. If you do have to change them a couple of times, or if they are really sick, you only need to tilt them a little bit. You're not going to give a death bath. And then 3 flat pillows and wedges. So we're able to turn them and such. And I got a heart pillow that they should have. I'm not sure what we decide. We're going to gift it in tele, or we're going to gift it over here to ICU. Either way, yeah, we have them stored in the ICU right now. So anyways, we got IV poles. So we need 3 IV poles at least. We got some for hemodynamics. We got some for not really for the cogent to have its own little cart. Either way, we have 2 brains. As I think to put 2, yeah, 2 brains, 3 channels each for worst case scenario. We got the little Scorpion, which is the multi-lumen adapters. We have all of our pressors going, and inotropes and vasodilators. Fluids, you get at least 2 bags of LR. LR should be your go-to. 500 of NS for hemodynamics. You can maybe get 2 of those bags because you might have an A-line CVP. You can do 2. You can actually retract. If you don't have the special 3-way hemodynamic setup that lets you do 1 spike to an NS bag, and then it's able to do your PA, your SWAN, and your PA, your CVP, and your R-line all in one. That's nice in that manner. I have it over here for hemodynamics. It's a 3-way hemodynamic line. It looks like it's just 1 spike into a bag, right? And it comes off 3 different. It's like a vamp system, and it has 3 vamps. And then you can put them to your different things. Yeah, we have them. I think it's in my office actually. I can bring it to the break. All right, so you have that guy. That's just a nice 1 spike. Otherwise, you need 2 bags of NS because that'll get you 4, right? What else am I missing down there? Labels. You're gonna labels for days. You're gonna label everything in the room. You're gonna label all the pumps. You're gonna label everything. You put a label on the forehead. It's like patient. Okay, right? So you're gonna have all kinds of labels there. And then what else? We got blood from OR, so you might have to return that afterwards. This is a heads up. And hemodynamic wise, you need a transducer holder. So our transducer holder can hold 6 things, or if you have a vamp and a transducer, like a single vamp, that will be all 6. Either way, that's one of your IV pulls. Pressure bag times 3. You might need just one if you have the one spike, but might need another one in case you have to give fluids rapidly or blood rapidly for worst case scenario. And the patient. So you want to think about what you need for the patient themselves. They need a glucometer. They're going to come back on an insulin drip. So because we want the sugar under 200 by day 1 and day 2. So they're going to have you're going to be doing sugars every hour with insulin drips. So we should have at least 12 go arounds. And if they can't come back on pressors, you should be doing a arterial sample or venous sample, essential sample. Restraints, some patients have anxiety. It's a crazy thing, but especially if your sternum was sawed in half. So we want to have restraints just in case. TED hose will be at least at the end of post-op day 1, they should get some TED hose. Otherwise, you can have the thigh high. It sounds like mountain high. You got mountain high, thigh high, SCD. What are they called? Not stockings, sleeves. There it is. All right, didn't even write it. I read it there. Anyways, OG tube if it's not placed already. We need a saline stump, all the things for an OG tube. Doppler is, I think we put a dedicated Doppler in the cabbage carts. That way it's doesn't get lost. So we have it, and those things are like $200 a piece. We can keep ordering more if we need to, but please don't waste them. Anyways, a pacemaker with batteries. So the pacemaker, they should come back on the pacemaker, but if they don't, we want to make sure we have this guy right here. We have an old school pacemaker that doesn't do AV pace exactly. We want one that can do AV pacing. The cath lab has a brand new one. So the cath lab has one, OR has one, and we have one. There's 3 pacemakers in-house. I've tracked them all down yesterday. And then battery. So you want to make sure you get a battery. And you don't store these with batteries because batteries can corrode. All right, I just took them out Halloween decorations, and they have batteries in it. So you want to make sure they don't corrode. CHE bath wipes, they're going to get that at nighttime. And bear hugger, they're going to come back cold like every other operating room patient. So I want to make sure we have bear hugger available, and the blanket as well. Apparently they sell bear huggers for golden retrievers. Cool. Dressings, you want a lot of dressings in case worst case scenario, they start bleeding. You want some gauze, a lot of 4x4s, pressure tape, just in case you have something that you need to apply pressure to, and you're able to let up the pressure a little bit. You can put some pressure tape. You can actually do something else. And then split sponges for chest tubes. All right. And what else? We got monitors. So the GE monitor is already mounted in the room, but you have to grab the cardiac output monitor right there in the middle, right? That's the Cogent cardiac output monitor, the CCO, continuous cardiac output monitor. And it has its own cables. One of those cables was $2,000, so please be careful with it. That cable specifically, the $2,000 one, will be plugged in the operating room and hooked up to their Cogent monitor. So that one will not, and if you disconnect it, then you have to recalibrate it. It's a whole deal. And what else? So the GE monitor for cables, also obviously all the pressure cables that we would need for a PA cath, a SWAN, and then our CVP, and did I say A-line already? An A-line. And then what else? So 2 splitters, because you only have 2 red ports on our GE box PDMs. So you need to have 2 splitters or 1 splitter at least to be able to get all those pressures transduced. And standard vital signs, you got just regular cables you would normally have. Plus, you should be using the 12-lead EKG setup. And why is that? What are you missing with a 6-lead setup? You're missing V2 through V6. And which vessels are those? That's the LAD. What else? And the circumflex. And what else? You can grab septal with the V1. It's the PDA, public display of affection. That's the other one that's going to be can be missed if you don't have a 12 lead in place. And really, if you have a patient come from cath lab, they should be on that. But with those things that dust cobwebs off the other time I took an Impella patient. Anyways, we have what else? Continued cardiac output monitoring. We talked about those cables. Those are all kind of wrapped together. They shouldn't get lost. And other things you need. You want to grab the cabbage cart, which has most of the stuff above, right? And the crash cart should be within eye line. You should be visible, right? So if you're getting a patient to 75, which these rooms right here should be our cabbage rooms because they're right close to OR. So like 75 through 78 would be our cabbage rooms. And the cabbage, the crash cart's all the way down by 82, six rooms down. So we want to kind of move it closer and plug it to a red outlet. And then the re-sternotomy cart, which is this guy right here. And we'll rebrand it a little bit more, but re-sternotomy cart needs to have all the supplies available for worst case scenario, which is opening the chest in the ICU, right? So you ask other facilities like once every 4 years, but the data says it happens once a year for like actual centers that do this pretty often. And we have a lot of sick patients in the Antelope Valley, unfortunately. All right, so the primary nurse versus the secondary nurse. So the primary nurse there is in yellow. And what the primary nurse is doing is they're getting a bird's eye view. They're always eyeballing the vital signs, right? They're the one that can be delegating. They say, hey, can you hook up the A line? We don't have an A line yet. Or can you go get me this? Can you do this? Can you do that? Because this person is the runner, right? They're the one that's going to be always getting things for the primary nurse. Okay, so they are there to support, do all the menial things like associating them, or the amount should be associated, but putting all the heights and weights or all the weights for all the drips. That's something that the secondary nurse can be doing. So going back to the primary nurse, they're the one getting the bird's eye view, right? They're the one that got a report from the CT surgeon or the CT anesthesia, or cardiovascular anesthetist, and that should be 1 hour prior. They should be able to give a quick report, either that or the OR nurse. But either way, they're going to follow the patient into the room and give handoff, right? You want to know what surgery, and you should already know because you read the H&P and the cath lab report, and you know how much % of each vessel they had occluded, right? So you want to know what surgery they did, what vessels, what they did, grafts versus lima, because that might have changed. Maybe they messed up and that something happened and they found it wasn't a viable conduit. You want to know all the things as far as what they did. Any complications that happens, like, oh yeah, we had difficulty doing this, or they never got they're still asystolic or really bradycardic post cath. We took them off bypass, so they're on the pacer now, right? Or they had excessive bleeding or something to that effect. And they have any concerns, like, yeah, it was a difficult intubation. It took a lot of effort. I had to use a fiber optic intubation. All right, so what lines I have in place and where? Epicardial wires, there's a standard for epicardial, right? The right atrium should come out the right side of the chest. The right ventricle should come out the left side of the chest, but that doesn't always happen. All right, you want to know if they are paced, what the underlying rhythm is, because they're the ones that put the pacer on. So they should know what the rhythm was when they put the pacer in place. And it's our job every 2 hours or so when we assess the patient when they're in the ICU is to see what the underlying rhythm is also. What else? So what drips are they on? Do pressors need to be given? Or what do they have in their pocket? Do they have neosynephrine in their pocket? How much did you give? Show me, empty your pockets right now, right? So that's going to be what they have, what's infusing, what the CT surgeon wants, right? Really, there should be no dopamine in sight, right? I've advocated for dopamine to be removed from the crash carts. It's a horrible drug. It should not be used anywhere in a critical setting, right? So all the evidence shows it's horrible. So that's not a thing. Also, neosynephrine is only for cardiogenic shock. It's really not, it's really like a last ditch effort unless someone's like super tachycardic, right? But otherwise, we have all the other great things. We have epinephrine drip, we have norepinephrine, we have inotropes and such, which we'll touch on. All right, what is their goal for cardiac index? The CI goal. So cardiac index usually is 2.2 for patients just post-operative. Any maxes in the drips, like, hey, when I hit 20 of Levophed, what do you want to do? Or when I hit 10 of epinephrine, or if they get how tachycardic do you want them to be? 120, 110, 100, right? Usually they're not going to want any systolic over 120, but when we talk about heart rate wise, what's too much for them? All right, so which one do they want to win first? Is all about our dual titrations, right? Make sure we have good things. Then you can tell your secondary nurse, please keep put that in. But if the cardiac surgeon is a good cardiac surgeon, they're going to make sure their CPOE is great, make sure they put all the orders in, right? But if they don't, then we got to make sure we get that done. All right, concentrate drips is a little thing from the cardiac surgeon group here. If all your drips are more than 70 mLs an hour, and it's going and you can't get the drips down in volume, they want you to start concentrating the drips automatically. So Levophed at 4 and 250, go to 8 and 250, or even 16. All right, if they can double concentrate the epinephrine, et cetera. What else? So airway complications. They have a COPD history. What's anything else we got to be concerned about extubating wise? Do you know the estimated blood loss? Was blood given intraoperatively? Do boluses or blood need to be given? What's their threshold? Usually the standard threshold is less than 7. And we should already have units on hold from preoperatively, right? And what is too much bleeding? So we talk about chest tubes. We'll get more detailed, I think, on the next slide, actually. So too much bleeding, usually more than 200 in the first hour is bad. And when we get the patient immediately post-op, you're going to be doing Q15 checks on the chest tube. And that's something your secondary nurse can be reporting to you, right? So, hey, I need you to remind you, hey, please get the chest tube every 15 minutes. Let me know what it is. And they tell you, oh, it's 75. Oh, it's 125. Oh, it's 150. Well, shoot, that's way too much already, right? You don't have to wait to the hour mark at that point. And assessment, are there any bleeding? That's our immediate concern post-operatively. Like day 2, we're worried about pneumonia. Day 5, day 7, we're worried about infection. So really immediately we're worried about bleeding and hypotension. Any new murmurs? Do they have a murmur ahead of time? They might have a new MI or might have something else going on. And then labs, they should have immediate rainbow of labs drawn, and we can then assess there's what they were preoperatively and postoperatively, if there's bleeding, if the creatinine's going up, if the coags are weird, right? And then are they diabetic, or do we have to, what's our concern there? So we need to make sure the sugar's controlled. So that's why we had those AccuCheck in the room. We had 12 strips, and now it's time to use the first one. Okay, the CT surgeon, the cardiothoracic surgeon, they're the one that's gonna be the point of contact basically for the whole ICU stay. Or maybe when we get used to it, it'll be the end of day 1, they can hand off to the intensivist, right? But anything cardiothoracic, pressure wise or bleeding wise should go through the cardiothoracic surgeon. All right, so again, the secondary nurse, they're the one up at the top right corner. That's a CABG patient with an OR. It's an accurate depiction. That's the one that's going to be, they're the ones going to untangle. They're going to do they're going to do the menial work. They're the runner. They're the one that's doing all these little things, right? And it's kind of staffing wise, we're going to have them pretty much be free. They're going to be the breaker. They're going to be the RRT nurse or the charge nurse. And really, it's like a code situation. Everybody's going to descend in the room at a time. You're going to have a lot of hands. But as a primary nurse, you can filter people out. We're good. I just need help on X, Y, and Z. There should be 4 hands of monitoring, so they shouldn't take their monitor off, just like the ER, until we have our monitor in place. Temp, we want the temp is good. What happens if the temp is low? What happens? Put a bear hugger on, but what are they at risk for if the temp is low? A bleeding, all right? And lab draws, they can draw the labs. They can do that first AccuCheck and report it to you. We should be doing labs every 6 hours, usually, and then labs daily after that. They can be checking your orders, make sure the order set's in place, make sure they got labs ordered for the 6 hours and also in the morning. They can mark outputs with a Sharpie or an indelible ink marker. Label everything. They can date and time things, make sure TKO fluids are going to the cordis catheter. There really should be any lumens immediately post-op that are just hanging free. Okay. Ensure everything's dressed right. Make sure everything's clean, dry, and intact. Make sure they're labeled. Make sure we know if there is some oozing, we've marked it. Pacemaker in place. We want to make sure we have all those things great. So it should not be asynchronous. That's usually an emergency button on there, but you can also change the modes if you're fancy. But otherwise, this should be in a default mode. We should know what the MA sensitivity is. We're probably going to write that on the whiteboard. And then documentation. So they can on the whiteboard, they can put the centimeter markings for everything, the weights, the estimated blood loss, the time of arrival, or the end anesthesia time, the EAT, right? And why is that important? The EAT for antibiotics. That's really the big piece nowadays is when the antibiotics need to be all 3 doses of Ancef need to be given. Okay. Usually, most things are weight-based nowadays, so to make sure that we have the right weight updated on the board and also on the inserter and in the pumps for that matter. Okay. And do you have an order for everything? Because your shift ends eventually, so you got to make sure the next nurse is able to get have everything accurate, because how much in handoffs gets dropped sometimes, right? And then what else? So again, they are the runner as a secondary nurse. Any questions on the primary and secondary nurse? What I misspell? Oh, so things to perform immediately post-op, day 0. So this is the first day in the ICU, right? So immediately you're going to get those labs, like we mentioned. There's a lot of rehash of the previous slide that I mentioned, but I want to make sure that we have all the labs ordered, and all those labs are going to let us know what the the blood gas, because we're going to blood gas within how many minutes? Within 20 minutes, because really by hour 1 post-op, they should be weanable. You're going to put them on SBT, and 30 minutes after that, you can pull the tube. So by the 2nd hour, you can pull the tube, right? And our goal officially is how many hours should we be extubating? By the 6th hour, right? Really, the STS requires you within 24 hours, but we're saying 6 because that's what the kind of industry standard is for a patient that doesn't have complications. right? Lactate trending up would indicate what? Poor perfusion of any kind. If they're getting septic, if they're getting cardiogenic, if they're getting neurogenic, they're getting some kind of decreased MAP for some reason, decreased perfusion to the extremities. All right, 12 lead, because patients can have MIs when they're on a ventilator, right? Patients can have MIs also post-operatively as a CABG patient. So we got to pay attention to that. Hemoglobin trending down, we got packed cells available. Creatinine trending up for an AKI of some sort. Mag and potassium should always be great. So K should always be greater than 3.5. That's usually pretty standard. I think the electric replacement right now says, is there a differentiation? I think I saw the distant past that it had cardiac potassium and just regular potassium replacement. Either way, you want it more than 3.5. And you should always have 2 grams of mag ordered to keep the mag greater than 2. So the mag hits at 1.9 on your chemistry, on your mag level, then you can give 2 grams to get it above 2. Okay, and you have units on hold. If their INR starts getting high, usually greater than 1.5, that's usually our surgeons want to transfuse FFP at that point. But we can be a little bit more distinct and figure out there's something else going on that's causing them to bleed. All right, AccuCheck on arrival. We have the insulin advisor. It's called post-cardiac surgery. So you just search advisor, and it's right there. Yeah, they're going to have insulin drip infusing from the OR, so they need to have the order in place. We must have a sugar under 200 on day 1 and day 2. And then chest x-ray. So they don't do chest x-ray in the OR, they do chest x-ray here. We have to remember to do it. They have to remember to order it. It should be, I'm pretty sure it needs to be checked on their post-op orders. It's there on the post-op orders, but it needs to be checked. So we make sure all the lines are in the right place, the tubes are in the right place, the ET tubes in the right place. So we have, so we know everything's good and not dislodged. And then head of bed needs to be 30 degrees. Back in the, for VAP prophylaxis, head of bed 30 degrees doesn't matter. Their evidence is extremely low. The head of bed 30 degrees decreases VAPs. Okay, well, we just do it because it's cool. But for patients like or CABG, we do it because it's going to actually drain the blood out of the chest. You don't want that blood to become a clot in the chest, and now you get AFib out of it. You can have cardiac tamponade because of it. You can have a lot more complications if your head of bed is not 30 degrees, right? So PUD-VT, we're still going to do that. That's still a cool thing to do. Pain management, want to make sure if we can, we're going to get opiates reduced as much as possible, get them on Tylenol. It's like Tylenol for cardiac surgery. Well, it's actually not, as you saw through their chest, but you don't want to, it's actually shown that it's, as long as you mitigate it with, Tylenol around the clock, and you can mitigate their pain. If they can't take PO yet, we can, because you got the chest x-ray right away, you can give ofiramib, IV ofiramib, which is your IV Tylenol. Hypothermia, hyperthermia. Hyperthermia is always not good. So that's, ofiramib can also be great for that. But otherwise, with the bear hugger nearby in case they get hypothermic. Titration wise, avoid hypotension and hypertension. So what's the highest blood pressure we'll accept? 120 systolic, right? We always want to map greater than 65, but for perfusion's sake and for perfusion of everything. But we want the systolic to be 120 or less because otherwise it's going to start bleeding through the grafts. Our antibiotics, we mentioned, 3 of them within 40 hours of and anesthesia time. And then rapid weaning of the vent. So we have a slide on rapid weaning. So we'll talk about that. But you're going to get an ABG within 20 minutes, which is going to start that process. And then post-op order sets, do we have all the things we need for tomorrow? Make sure we're not missing anything. So hashtag goals. What goals we need? We want a sugar. We want extubated. We want them to be mobilized. We'll talk about mobility coming up. But we want them DAPT abs, and we'll talk about DAPT abs shortly. We want antibiotics. We talked about that. And then we want no complications. So the last section we'll talk about at the end of lecture today is going to be no complications, all the complications that could happen. So we want to avoid those if possible. What do you need to chart? So all the charting, because that has to happen eventually. So they need to do a full assessment. That's like a head to toe. That's going to be Q1 hour times 4. So it's a 1-to-1 patient, it's a 2-to-1 for the first hour, just about. So you should have time to do a full assessment head to toe that you're assessing all the things. You're doing peripheral vascular assessment because they probably did a graft somewhere. They did a radial or if they did a SVG. You're going to assess their neuro exam, all the things we can assess. And then after that, Q2 times 12 hours. And then we can switch over to Q4 like standard. All right, hemodynamics for the first hour, every 30 minutes, or maybe 2 hours. And then after that, every 2 hours to 4 hours as they get more and more stable. And we have all kinds of hemodynamics we talked about in the hemodynamic class. We want to make sure all those are great. All right, SVR, PVR, wedge pressure, right? SCVO2 will be on our cardiac output, our continuous cardiac output. If we do have an intermittent swan, we could do that, Q1 hour times 4, and then Q4 hours, because that's a whole 10-minute ordeal to make sure everything's grabbed appropriately. All right, so we do recovery vitals like any other OR patient. All right, but it's going to be a little bit more tight. We do Q 10 minutes times 1 hour, and Q 15, Q 30 times 4 hours. So we're kind of spreading it out some more. And technically, you could do Q1 hour afterwards if they're stable. And then drainage. We're going to make sure we're looking at all the drains and charting all the I's and O's. Make sure the chest tube is that's in place. It's not bleeding and oozing. But for the first hour, you're going to assess every 15 minutes. And if that 15-minute interval has 100 cc's or more, right? So you assess every 15 minutes, and bam, it's 100 cc's in 15 minutes. That requires a call to the cardiothoracic surgeon, right? That's not like where sometimes you do a turn left to right, or they get up in the chair and bam, 75 cc's comes out, right? Because they had all that pocket of blood sitting there. That's different. This is immediately post-op. They should not have that in the first hour, okay? As we mentioned, 200 is always bad. First hour especially. After that, 150 for every hour is not good. And urine output's important because we want the kidneys to be functioning. All right, so post-op day 1. So what should they, so we did post-op day 0. They should have been extubated already. If they're not, technically we have 24 hours, but we want them on a cannula. We want them moving around. We got them up in the chair. Family can already be seeing them. This should be happening within 2 to 4 hours post-op day 0. They should be dangling. And then post-op day 1, they should be in the chair. After that, after they're extubated, they should be 3 times a day. They should be in the chair. Okay, I think I have it on here as far as what their mobility is. Otherwise, it's coming up when I talk about mobility. Anyways, patient in chair for all meals, TID. They should be eating clear liquids after 1 hour after extubation, and the next meal can be cardiac or diabetic. It's a multidisciplinary approach, so everybody needs to be involved, including dietary. So you get them involved to do teaching if they're diabetic, teaching if they don't know anything about or they only eat Egg McMuffins. And then insulin drips. So that will finish in 24 hours. Really, that should be 48 hours, but you can switch them to sliding scale if they're good. But we want to make sure we have that sugar under 200 by day 2. Also, post-op day 1 should be less than 200, and post-op day 2 also needs to be less than 200. All right, so it will finish, but the goal is still to get it less than 200. All right, electrolyte protocol, just like before, keep the K and MAG high. PA catheter can be removed day 1 unless they have complications. The cordis will be removed before they go to tele. And then pacer wires will likely be removed on tele. They could be removed by end of day 2 if they have no issues, but if they are bradycardic still, they have runs of AV block, they have runs of 3rd-degree blocks, they're probably going to have those pacer wires for a good 7 days. But after 7 days, they usually don't work, and they have to get some other permanent solution, like a permanent pacemaker. All right, so what else? Education, did we document this in the IPOC? We get the booklet. Are we on page 20 of 58 of our booklet, all right, to go over all the things that are in that booklet? And we just got to reinforce that. And our goal is to be tele by the end of day 1, and that for a perfect patient. All right, if not, the intensivist might take over at this point to manage them in the ICU. Depends on how sick they are. And then post-CABG meds, all right, so they need to have what's called DAPT abs. All right, so DAPT, all right, you're going to DAPT is dual antiplatelet therapy. They need to be on aspirin through the whole peri-op period. So pre-op, they should be on aspirin, and post-op, they should be on aspirin. And only if they're bleeding, that'd be a reason not to, right? But DAPT, dual, we need to have aspirin. What's the other piece? What makes it dual? Is dual antiplatelet, but aspirin's antiplatelet. What else is antiplatelet? P2Y12 inhibitor, that's ticagrelor or clopidogrel. They need to be started on both of those, right? So aspirin definitely within 6 hours. The clopidogrel ticagrelor is really, before discharge, but we can start at day 1, post-op day 1, like the slide's talking about. ACE inhibitors and ARBs, that is the A in ABS, right? So we got A, ACE inhibitors and ARBs. So A for ABS, B for beta blockers. And which beta blockers? Only one of these 3. So it's one of the MBC tune, right? So either metoprolol, bisoprolol, or carvedilol. One of those 3 needs to be started, and they should have already been on these pre-op. The only reason why you would not be on these guys would be what reason? Really Brady, high pressure requirements. That'd be like the only reason why you would not be on these. But by discharge, 100% they need to be on discharge with these. And then statins, you can start them right away. And then calcium blockers, amlodipine. That's only if they had a radiograft. There's a little, I gotta ask, like if they have CHF, it's usually a contraindication to be on a calcium blocker. So, but it's kind of like risk versus benefits. Do you want your heart to vasoconstrict, or do you want to have a worsening CHF? And like if you have the vessel, you might get better CHF. I don't know. So yeah, so that's going to be times 1 year. When they're again day one, they should be extubated. They should have good blood pressure. They should be in good shape. Okay, and then PO analgesia. That's where we can use Tylenol around the clock, right? Not NSAIDs, not the tramadol is the NSAID, right? Toradol is the opiate. So not tramadol, not anything NSAID-E like ibuprofen or anything like that going home, because what happens if you give NSAIDs to someone with a MI or the CABG? They bleed, but something a little more, just a little tiny little bit more serious. They get ventricular free wall rupture. Their ventricle pops, right? If you take NSAIDs post heart attack, all right? So that is not good. Also, if you have renal failure, not good either. All right, that's going to also worsen your renal failure. So NSAIDs are really bad. Aspirin is a quasi-NSAID and Tylenol is a quasi-NSAID. So, but full-blown NSAIDs, like everything else besides aspirin and Tylenol, are not good. What's that?
Why does it cause it?
It impairs the inflammatory process. The inflammatory process is involved in making scar tissue and such. So, or not making scar tissue, but making healing happen. It doesn't heal right, and then it heals weird, and then it pops post-MI or post-CABG. All right, so then opiates, we want to try to reduce them as much as possible because that causes delirium. Then you're in the hospital longer. Then you get a pneumonia. That's not good. All right, and bowel regimen. We're gonna do show me loose bowels or else. All right, we're doing Senna. We're doing M for Miralax, L for lactulose, B for bicicotal rectal, and then it's or else E for enema. All right, it's coming out. I'll show you what they did in 1958. It blew me away. Like 2005, they did 3 stack shocks. And then in 2000, they took away the digital rectal exam to break an SVT. I wasn't around 2000. I was around 2000, but I wasn't a nurse then. But yeah, so that came out. They esteemed ACLS took away digital rectal exams for SVT. They took away stack shocks 2005. What's that? That was a thing. Yeah, it's like, oh, they're an SVT. Turn over. Put a lube finger. And that broke the SVT. It works. You haven't bear down, but how about they bear down around a finger? You had a council on a mountaintop somewhere, and they're like, you know what, guys? Well, but maybe they did other things too. But anyway, you know what, guys? He's like, let's do this, and that's so they put it out there, and it was there for like 10, 15 years. Either way, I'll play the video on what they did in 1958. It blew me away.
Bring it all in there.
The treatment of cardiac arrest in 1958.
Oh wait, don't show it yet.
In any patient under the influence of an anesthetic,
It's 8 minutes long. So you got time.
Chair, as minor casualty, during a major operation, or during cardiac catheterization, heart action may fail at any time. What's the trouble? Has something gone wrong? The heart appears to have stopped. What would your reaction be? Injecting drugs or using stethoscope wastes precious seconds.
They didn't have BLS, they didn't have ACLS.
Speed is vital, as in less than 3 minutes, anoxic brain damage will be complete. If irreversible changes are to be avoided, cardiac massage must be started within 1 minute. 3 tasks must be carried out in this time. 1, first 15 seconds, confirm the diagnosis, feel for the carotid pulse. 2, second 15 seconds, make sure that the airway is free and administer oxygen. 3, you have 30 seconds left in which to open the chest and expose the heart. Incise at the 5th intercostal space.
Let it open.
Push the ribs firmly apart to make the heart more accessible. Now massage the heart between the flat of your hands. The first 60 seconds are vital. So let us go back and see how these 3 maneuvers are carried out in practice. Within the first 15 seconds, Make certain that the heart has really stopped. If you cannot feel the carotid pulse, or if blood pressure is no longer recorded, the diagnosis is confirmed. During the second 15 seconds, ensure that the airway is clear. Administer oxygen and check that no other gas is in use.
50 seconds, try to check the pulse, 50 seconds for O2, and then 30 seconds.
Now prepare to open the chest. Feel for the fifth intercostal space and incise with any sharp instrument that is at hand.
No gloves.
Absence of bleeding confirms your diagnosis. Make a second and deeper cut to divide the muscles and pleura. Spread the ribs firmly apart to make the heart more accessible. Then hold the heart between the flat of your hands and start cardiac massage at once. Wait for the ventricles to fill between each manual compression. The rate of massage will depend on the rate of filling. Take care to avoid rupturing the heart by undue pressure with fingertips or thumbs. Where there is limited access, compress the heart between one hand and the back of the sternum. At this stage, the trachea can be intubated at leisure so that the lungs can be controlled in the open chest. Now that oxygenated blood is steadily going to the brain, you have more time to plan the next step. If the heart has not responded with regular contractions, a more detailed examination will be necessary.
Yeah, it looks like it's
Ask for rib spreaders, scissors, swabs and long hemostats, adrenaline, and the defibrillator. Continued massage gives you time to change to a more adequate and aseptic technique.
Joe was going home. Better access.
Where's that one in it? Huh? Oh, it's really slow. Yeah. Maybe it's like 20 beats a minute. And then
There's no 10 seconds off the chest. It's like.
And the guy survived it, then he died from the infection.
Now, open the pericardium for a closer examination of the heart. You will find one of two possible conditions. If the heart is distended, blue, toneless, and without movement, this is asystolic arrest. Unless it is gravely diseased, such a heart will respond to continued massage and adequate oxygenation. Alternatively, you may find a small heart with rapid fibrillary movements. It may be pink. It has fair tone and feels like a quivering bag of worms. This is ventricular fibrillation. Continue massage at once to restore good myocardial tone and then defibrillate. If after several minutes tone has not returned, administer a stimulant before defibrillating. 10 cc of adrenaline, 1 in 10,000 are injected into the left atrium.
Blocks were hard.
Like in Pulp Fiction. Right? This is Pulp Fiction.
Right.
Oh, yeah.
Adrenaline.
In the meantime, the defibrillator is assembled. Give a very brief shock of between 150 and 250 volts, depending on the size of the heart. Should this fail, continue massage and repeat with one more shock. It may be necessary to use 2 or 3 quick shocks. Ensure firm contact across the ventricles. The initial arrest of the heart is abruptly followed by a resumption of normal rhythm.
That doesn't look normal.
When the circulation has been re-established and is maintained, arrest hemorrhage, clean up, and close the wound.
The lungs.
You have seen how cardiac arrest can be treated successfully. Speed is vital, as anoxic brain damage will be complete in less than 3 minutes. Therefore, do not take more than 15 seconds to confirm that the heart has really stopped. During the next 15 seconds, ensure free entry of air to the lungs. Open the chest with any sharp instrument that is at hand and massage the heart between the flat of your hands. In this way, almost all hearts can be restored to a normal rhythm.
Yeah, 60 years from now, all the stuff we're doing,
Yeah.
it's gonna look like that.
Right?
Yep.
AI will take over.
Yep.
As far as next is cardiac arrest in the ICU, obviously, of a CABG patient, but this can happen on tele. So we can have a tele patient that arrests as well with a sternum with sternal precautions. So that includes making sure that we are aware of what to do if a patient with a CABG arrests, all right? So it occurs about 5% of surgery patients. And if we do 400,000 patients per year, it does happen, right? Most occur in the first 24 hours though. The other half are in the first 3 hours. Or sorry, 50% of them occur in the first 3 hours as your highest risk for bleeding, highest risk for cardiac tamponade, highest risk for an arrest, right? There's no established American guidelines. Otherwise, there's no ACLS. So all we've done is adapted things from the European Society and a little bit from the Society of Thoracic Surgeons, which is international, right? So it's called CSU-ALS. So it's like CSI Miami. We got, I think the SU stands for surgery. So cardiac surgery ALS, right? It should have been CS. Anyways, so goals. So the goal is to ID the underlying cause, just like H's and T's are for a patient that's in ACLS encoding. Our goal here is to find out the most common reasons for someone that might be bleeding, might be arresting with a CABG. So usually it's arrhythmia related. Well, obviously it's arrhythmia related, but it might be like a VFib, VTAC, or it might be someone that is bleeding like a tamponade, and that causes like a PEA arrest or something like that effect, right? So perioperative MI, about half of all arrests. We have EKG changes. So what you look for, we'll kind of recap on the EKG changes. We talked about complications in the last section. But tamponade, so you have Beck's triad. What is Beck's triad for cardiac tamponade? Got low blood pressure. You got JVD, muffled heart sounds. And nobody can tell me that that's muffled or not muffled unless you're like really, you maybe record on your echo stethoscope. Like, see, like the decibels is low, right? So anyways, yeah, you have, the big thing is you have a hypotensive patient and you have JVD. And who can accurately assess JVD with a ruler and a flashlight with the lights dim and the head of bed at 30 degrees? I don't know, but you can have a CVP in place, right? The CVP starts going up, it's starting to hit like 20. That's really someone that's, either extremely fluid overload or they have tamponade, right? There's not many reasons for high CVP. For low CVP, it's anybody's guess. They could be fluid responsive, not fluid responsive. There's not evidence for that, but there's strong evidence for high CVPs. All right, so then we have hemorrhage. What's the chest tube output? What is too much output again? Greater than 200 in an hour, 150 after that first hour, or if you're like immediately post-op in the first hour, every 15 minutes you're checking, and it's more than 100 in any of those 15 minutes, that is excessive, right? And then arrhythmias, do they have VFib, VTAC? That could be because of the MI. They could be asystolic or PEA, but VFib, VTAC is the most common. So our goal is to shock them out of that rhythm, right? So other things might be ET malpositioned. Are we assessing the end tidal CO2? That will tell you if you're in the right position. Is the exhale tidal volume and inhale tidal volume appropriate? Are they matching up? Is the chest X-ray checked? Do they have a pneumothorax? Worst case scenario, right? Is the chest tube in the right place? Is there a leak there? And they got a tension pneumo happening. All right, IV infusion errors. We gave too much of a medication or flushed a vasodilator. That happened. I was at clinicals at AV, and then night shift gave reports day shift, and they said, "Hey, whenever I give a medication via that triple lumen, I did give one last night, and they went super bradycardic." So, okay, I think no, someone didn't flush it. Either way, so we have tension pneumothorax we mentioned. We got absent breath sounds on one side. We got rising peak pressures on the ventilator. There are clues pre-op or pre-code, and we should be able to recognize this because there's a one-to-one patient or only patient, right? So identification in a CABG patient of someone that's arresting. So the heart rate's 50 to 120, and there's no pulsatile movement. On the hemodynamics, the A line starting to get flat, and they start to get dampened. That could be there's not adequate movement of the heart. The heart is going into PEA, basically, right? The heart is not ejecting blood, but there's still electrical activity, right? And then hemodynamics, are they in a shock state? So the bottom left there is a few of our shocks, right? So they have obstructive shock. What does obstructive shock do to? Something obstructing the flow of blood. So it's like most commonly in a cardiac surgery patient, it's going to be a cardiac tamponade, right? And we mentioned the CVP is going to be high, obstructive shock, right? That starts to rise. And obviously every single shock state is going to have a low blood pressure. So that's a moot point. But what's unique about obstructive shock is it's trying to eject blood, but it can't. And it's going to keep trying and keep trying and keep trying. So your pressures inside the heart are going to be high. You can see the wedge pressure is high in obstructive shock because it's trying to eject the blood. It's also high in cardiogenic shock, but that's because it can't eject the blood. So the pressure in the heart is high because it can't eject the blood. And there's other clues too. The cardiac index is here, right? Cardiac output, cardiac index. Yeah, the cardiac output is going to be low in cardiogenic shock because it can't pump blood. But in obstructive shock, it can pump blood if there wasn't somebody in the way, right? So that's a way to differentiate cardiogenic versus obstructive shock. Neurogenic's on the list there because that's not really a priority for cardiac arrest patient, unless someone had like a widespread, I don't know what situation that might happen. But either way, we have distributed shocks, which neurogenic could fall under. That's where you have just really, really low SVR. SVR is how much vasoconstriction you have, right? How much vasodilation you have. And a distributed shock, you're distributing all the vascular is distributing all the blood everywhere, and it distributes the blood everywhere because everything vasodilated, right? So the SVR would be low. And what's a low number for SVR? Less than 800, right? I mean, if you're in Europe, they call it Wood units, and it's like 1 to 80, 1 to 70, somewhere in there. Either way, 800 dynes or is less than that is a low SVR, which means you're vasodilated for some reason. Maybe they have a surge response from the bypass earlier, and 3 hours earlier. Maybe they have a septic process happening if it's day 2, day 3, which is more rare, but it can happen. And when you have sepsis, you can see the SVR is extremely low, right? And the heart initially is going to try to fix that, right? It's going to try to increase cardiac output in response, but it's going to eventually peter out because the surge response and the sepsis response actually interferes with mitochondria. That's why you have lactate elevation, interferes with heart function. That's why you have a depressive cardiomyopathy with septic shock. So these are all the things you would see at the bedside that you'd be able to assess and trend, right? So what else? On hemodynamics, so also with obstructive patterns, the pressure in the chest we mentioned are rising. So the CVP goes up, and the pressures actually equalize in the chest. So when you're trying to eject blood, and there's something in the way, like a huge PE or in this case, cardiac tamponade would be more common. If it's trying to eject the blood, you're not going to be able to get a systolic diastolic phase anymore, right? It can't eject any blood, but the pressure in the chest is going to rise. So everything's like equaling out like 20 to 40 points, like a CVP, the wedge, and the PA pressures, like it's usual PA pressure like 25/10, and it's like both of them are 25/25. It's like, what the heck? And why is my waveform dampened? That's because you're in tamponade, right? And end-tidal CO2 tells you if you are perfusing. Well, yes, it's ventilated, but also it's perfusion because your right ventricle can't give the blood to the lungs to exhale. That means your right ventricle is not getting blood because you're in a shock state, right? And arterial diastolic blood pressure, that starts going down, and it's less than 20, you're for sure not in a great state. And pulse pressure, what is pulse pressure? Systolic minus diastolic. So usually your body will compensate. The SNS will fire off and you vasoconstrict, and that should rise, right? So if you have an effective SNS, you have vasomotor tone, you have a vasculature that can respond, like in cardiogenic shock, you can respond. Your SNS works just fine, right? So when the output's low, your blood pressure is low, your body vasoconstricts, your pulse pressure narrows. And obstructive shock, same thing, your pulse pressure will narrow. Septic and distributed shock, it would widen. So those are things we can track on the monitor. Also, I put some screenshots of cardiac tamponade. It has a seesaw pattern because of the way the heart is just washing inside the chest. And it's going to be, you can see it with inspiration, you're putting pressure into the chest and it can't fill. So you can see the drop in the A line. All right, tracing. Bottom left in the middle. That's it. That with inspiration, you have a, I'm not sure why I'm not plugged in and not walking around with this, but anyways, so you have a drop in pressure as you inhale. So we inhaled here. So here's inhalation, here's exhalation. Sorry, exhalation is the next cycle right here. So with inhalation, you push the air into the chest, the heart couldn't fill with blood. Therefore, it's going to be, you're going to have a poor output of that during inspiration. This is with a patient on positive pressure ventilation. It'd be different with someone that's spontaneously breathing. But you can see these PA pressures are starting to go up, right? They're starting to equilibrate. Their pulse pressure is narrowing. These are signs of obstructive shock. All right, so interventions, what do you do with this? So what are the, if it's not ACLS, what is it? So the goal is to do a re-sternotomy within 5 minutes. So within 5 minutes, we have to open the chest and do internal cardiac massage, right? So that's if the electrical therapies fail. So what we're doing is electrical things before we actually open the chest. The goal is to open the chest as fast as possible. And the only time you're going to actually start doing CPR and potentially mess up the chest, break ribs, and obstruct and get rid and make grafts not be grafted anymore would be after the 1 minute mark. So you're just going to sit there and let the patient be without a pulse for a minute, right? There are a few things you can do. So there's a few little asterisks and exceptions there. But basically, if you're VFib VTAC, which is the most common one, we're going back to 2005 and we're doing 3 stack shocks. So you're doing 3 stack shocks and you're assessing if what the change is, if that broke the rhythm or not. And you got a return of pulse, a ROSC or a diastolic elevation or an end tidal CO2 elevation. So you do 3 stack shocks, one after another, and max dose 360, 3 stocks right away. And your patient should be on the pads anyways, right? You saw your patient deteriorating. The crash cart's always within view anyways, right? So that should be the pads should be in place so we can do those 3 stack shocks right away once they lose their pulse, right? And the whole goal is to get those 3 stack shocks within 1 minute. At the 1 minute mark, if there is no ROSC, then now we can do CPR, which is the next phase down here. So that's 1 to 15 minutes. You're doing CPR, and all you're doing is doing CPR until they can do re-sternotomy. Okay, so VFib VTACs, and what else? What if it's not VFib VTAC? We got 2 options. It's either asystole or PEA, right? So asystole, usually what we do in asystole, nothing, just thoughts and prayers, right? That's all we got to do, CPR and epi. Well, first of all, we're not going to do epi at all. That's 100% off the table. That's not going to be given during this. The only time it would be given is if the cardiac surgeon said, yes, go ahead and give some epi, right? And even then it'd be like a half dose, like a 0.5 or 0.3 cc's. It would never be a full dose of epi. A lot of people are trying to get epi out of ACLS algorithms because it has a lot of bad outcomes. Anyways, so asystole is you're going to pace it. What the hell? Right, you're going to pace asystole. So that is what you do. So you do it asynchronous or DDD mode, and you make sure it's paced at 80 to 100 beats per minute at a max output. So usually on the defibrillator, you just do just enough, and once you get that, you just 2 MAs more. But here, no, you're going to crank it all the way up, right? You crank it all the way up, and you're going to try to pace them out of that rhythm. Okay. If they're bradying down, pace it. Right, and the same kind of thing. They got no pulse and they're bradying down. That's technically PEA, but they're going bradying down to nothing. So you just pace it, and you pace it for how long? 1 minute, and then after 1 minute, now it's time for CPR. All right, so you're just gonna sit there and just hope. And then there's really thoughts and prayers, and you can go cry in the cry room too. All right, so you're gonna make sure that you're gonna get and then at 1 minute mark, nothing. Everybody lock eyes. You can say, okay, now it's CPR, and you're gonna get really nervous because you have a fresh cardiac surgery case right there, and then it's time to start doing CPR. All right, if it's PEA, that means it's not asystole and it's not VFib VTAC. So you got like sinus rhythm on the monitor, but you got a dead A line, right? You have A line that's flat. Then you're gonna do CPR right away. That's really the only exception where you do CPR right away. Okay, so again, it's CPR until re-sternotomy happens. So re-sternotomy is the only time they would not officially do it is if you actually got a systolic greater than 60, then they would consider some other things. For VFib VTAC, you can give amio, but that's after you started CPR. So it's like, okay, I did 3 stack shocks for VFib VTAC, no ROSC, start CPR. and then prepare amio, give the amio. And you can shock every 2 minutes with VFib VTAC. Okay, so then afterwards, our whole goal here is to get them on, get them re-sternotomized, but also they might consider putting an impella in or a VA ECMO or doing a balloon pump. They could use that as a bridge therapy. Okay, so again, our goal here at the 0 to 1 minute mark is to do, it depends on your rhythm, just like with regular ACLS, but again, it's modified. Okay, so again, it's 3 stack shocks. 2005, 3 stack shocks went away, but early 2000s, oh yeah, that was it. You got the hairdo, you got 3 stack shocks right there. All right, so early 2000s starter kit. All right, so yeah, so again, you have team members just like with ACLS. So team number 1 is the one doing CPR, and they got to hold back, right? They're going to lock eyes with every single time. Can I do it? Can I do it now? CPR, it's me. Okay. Now the only time you let them go is if what happens? You got PEA. So you got PEA. How do you know you have PEA? You have an A line, right? A line is there's nothing on the A line, right? Or you have a vented patient whose end tidal CO2 is less than 20, and you do not have asystole, and you do not have a bradyarrhythmia that's bradying down asystole, and you don't have VFib VTAC, then yes, you can start doing CPR immediately. Otherwise, we have options, right? We do 3 stack shocks for what rhythm? VFib or VTAC, right? And then we got someone at airway, just like before. You do no PEEP. Why do you no PEEP? Because you don't want that extra positive pressure in the chest, right? They can assess for tracheal deviation. That could be their job up top. There's something called the trail sign. That's where one head of the sternocleidomastoid is more prominent than the other. That tells you have tracheal deviation, okay? Or you have a goiter or a thyroid mass, right? So they can assess lung sounds while they're up there doing bagging. It's like, do you hear anything, right? So they might have a pneumothorax, right? And then defib pacing, you're doing 3 stack shocks, right? Only for VFib VTAC. And if it's persistent VFib VTAC and you're doing CPR, you can shock every 2 minutes, right? If they're asystole Brady, they are setting the pacer to what? To max. Max MAs, 80 to 100 beats per minute, and they are pacing away. And then team lead, that's the ICU charge nurse or the ICU nurse, the primary nurse. They're the ones that are following the protocol until we get more people in the room. And they're looking for reversible causes. Like, hey, my pressures were going up. My CVP was like 25. It was super weird. My PA pressures, they were like 25 over 10, and now they're like 30 over 30. I don't know what's going on. So that, my friend, is a what? Tamponade, right? And then drugs. So we're not giving epi, we're not giving atropine, right? So what are we giving? Or the only drug we can give during this whole CSU-ALS is amio, and that's really once compressions have been done. All right, the IC coordinator. So that again, it can be if they're not already the team leader, you might have someone else there, and they're the ones that are facilitating, making sure people are getting there in time. They're calling the re-sternotomy team, which is the cardiac surgeon. They're calling the house supervisor, making sure they're en route, making sure the OR is being called, because there needs to be a whole OR crew for this, right? Any of the perfusionists on call. The perfusionist for the last 5 years with no cabbages has been making $5,000 a month just to be on call. Right, so that we can make use of them. So that's why you're here, and you have to be here within 20-30 minutes. All right, re-sternotomy cart needs to be. That's why you have a re-sternotomy cart. This guy right here is always within eye line when you have a CABG patient, because that needs to be brought into the room. Okay, and you need a chest tube. You might need to get the chest tube in, the needle thoracostomy in our little camping deal. All right, what else? So additionally, you might have a scribe there, someone getting equipment, some crowd controller. All right, so that's the deal with that. How long is this video?
My patient just went into VF suddenly.
Okay, so this is a cardiac surgical patient in VF. We're on the red portion of the CALS algorithm. Can we get the re-sternotomy trolley ready and someone gowning and gloving now, please? Ruby, you've got the defib. Okay, we won't start CPR. Let's get the defib on first.
We have to edit the buttons.
Okay, just putting pads on.
The pad should have already been in place.
Okay, just charging.
Unless it was all of a sudden. What are we doing? How many shocks?
Okay, we're in a shocking
3.
rhythm.
We're not checking pulses, we're not doing anything.
Shocking patient.
3 stack shots.
Okay, still in VF.
Also at max.
Still in a shockable rhythm. Everyone clear. Shocking patient and charging.
That's important because we don't do 3 stack shocks. If we're going to get back from the chest, you're going to make sure you are clear.
Still in a shockable rhythm. Everyone clear. 3rd shock. Okay, and
Okay, remains in VF. Start CPR, please, Ray. You guys, as soon as you're ready, we'll open the chest.
I'm on drugs.
You're on
I've
drugs?
turned off all of the infusions.
Sure. Can you get some amiodarone drawn up, please? 300 milligrams. Jason, you're on airway. What
Yes,
have you found?
we're on 100% oxygen. The airway is patent, and there's air entry bilaterally.
Great. Okay, has the 7 call been put out?
Yes,
Linda?
the 777 call's gone out.
Great. Okay, Ray, they're ready with the drape now, so step back.
Okay, Ray, we just need the dressing off, mate, but leave the deeper pads on. Thank you.
Scalp is here.
All right.
Tray, please. Tray.
Yeah, do CPR
So you can
thoroughly.
see the wires here.
So you can see the wires.
We're cutting all the wires in place. We're gonna have rib spreaders. You're gonna spread the rib, and you're going back to square one.
All right, the wires are out. Choose
I've got 300 milligrams of amiodarone.
Yeah, so give that now, please.
in.
Okay, what can you see?
There's no blood, but it is fibrillating. Can we get the pedals? And when you charge to 20.
Internal defib pads currently are in the OR. We have one set.
charging now, it is charged, so you can discharge when you're ready.
All right. And shocking.
Okay, I'll charge again.
I've given 300
Oh,
milligrams of
okay.
amiodarone.
Okay, we've got Ross
Fibrillating.
back, guys. Okay, we've got a rhythm back. Looks like sinus rhythm. And we've got a map of 67. Well done, guys.
Right.
Once they're inside the chest, are they given it another 360 when they're shocking it? Then?
No, sorry. I think I'd put it there. So the internal paddles right there under 3. The internal defib is with internal paddles, and it starts at 20, max of 50 joules.
Oh,
It's reduced.
okay. Right, right.
All right, re-sternotomy cart. So
Next slide.
Sure. There was videos of actual trauma and traumatic arrest because it's the only other place you would do re-sternotomies, or not re-sternotomies, but cracking the chest would be with a traumatic arrest. Okay. So yeah, so again, the cart should be outside the room available to you, right? And it must be restocked and checked routinely. So we'll get a process exactly for that. We have all the supplies there, but someone needs to check it pre-CABG. If you know you have a CABG, you want to make sure that the cart is up to date and signed, right? So again, you would notify the re-sternotomy team. Who's the re-sternotomy team? Someone who could do a re-sternotomy. That'd be the cardiac surgeon, right? And usually they have the RN first assist or someone from the OR that can help out, right? Notify house supervisor. They're the ones that can help get the OR crew in. They're the ones that can contact the perfusionist, contact the CVO RN, and the surgeon assistant will get sterile. And you want to know the gown and gloves. And you want to make sure the rest of the room should mask in nowadays, but also they should put a hairnet on if they are going to be getting close, but that's not 100% the priority. But again, in the cart, you're going to have a rib spreader, you're going to have sternal wire cutters, you're going to be cutting right here, the chest open, and that's going to be the goal. And this is what you do for internal cardiac massage if they ask you to. You're gonna make sure it's between both palms, just like the 58 video. You're not gonna be doing to your pads, your fingers. It's the whole thing. And you're going up because the heart ejects from the bottom up, right? So I think this is a video of the cardiac massage. So it's going upwards. He's not really doing it right though, is he? He's actually going downward. The apex, it should be going upwards towards the palm of the hip up.